Assalamu alaikum. Last lecture we talked about history taking, and in this lecture, inshallah, it's about clinical examination, obstetric examination. First of all, greet the patient, confirm you are speaking to the correct patient, confirm identity of the patient, introduce yourself, include your name and position. Briefly explain what the examination will involve using simple language. Obtain consent from patient to proceed to examination and offer a chaperone. Provide opportunity to pass urine before examination. First, because pregnant women have frequency and examination may take a longer time. Also, because abdominal examination with a full bladder will be painful to the mother. Position the patient on the clinical examination couch with 30 to 45-degree angle for initial assessment, mainly at general examination. Make sure patient comfortable. Wash your hand and dress PPE if appropriate, personal protective equipment. For abdominal examination, lie dorsal position with slightly flexed thighs. In late pregnancy, make a left lateral tilt 15 degree to prevent aortocaval compression by gravity uterus. Expose patient's abdomen from pubic symphysis up to the sternum. Ask patient if they have any pain before proceeding with clinical examination, especially palpation, and avoid area of pain. Ensure patient's privacy. All of these steps will be before proceeding to clinical examination. As we know, we start with general examination. We start on the right side of the patient and comment on general condition. Gauge if patient walking and general look, it looks well or not. Level of consciousness by Glasgow scale, and if a patient oriented to time, place, and person or not. Patient lying comfortable or dyspneic. Body build, weight and length, is it average weight or obese? Length, is it short, tall, or average length? Comment if a patient cannulated and catheterized or not. If patient cannulated, comment the size of cannula, and if the patient catheterized, comment on urine output volume. Vital signs: pulse, temperature, blood pressure, and oxygen saturation. In oxygen saturation, please specify if it is on room air or patient on oxygen. Hands, look for pallor, palmar erythema, and temperature. In a pregnant woman, due to hyperdynamic circulation, usually hands will be warm. Also, pregnancy is a common cause of palmar erythema due to hormonal changes, mainly increased level of estrogen. In nails, comment on colonychia, which is also known as spoon nails. It's an indicator of hypochromic anemia, male iron deficiency. Also, check for nail clubbing and assess for capillary fill time. In hands also, don't forget to check for pulse rate, rhythm, volume, synchronicity, and measure blood pressure. In the face, colwasma, it's one of the pregnancy symptoms, which is hyperpigmentation, mainly in the cheeks, due to increased production of ACTH and melanin. Check for anemia and jaundice in conjunctiva. Mouth, for anemia symptoms, central cyanosis, oral hygiene, artificial teeth, and dental care. Neck, for thyroid enlargement, which is a physiological enlargement or physiological goiter in pregnancy, and check for lymphadenopathy. Breast examination by inspection, examine for breast symmetry, visible lumps, surgical scars, skin changes, secondary areola, which is mainly in primary gravidas, nipple for cracking, fissuring, and ulceration. The purpose is to correct any abnormality, mainly nipple abnormality, to make breastfeeding easier immediately following delivery. Breast examination by palpation. There is 6 areas, 4 quadrants: upper medial, upper lateral, lower medial and lower lateral, nipple and axillary tail of the breast. Searching for any palpable mass. Don't forget for axillary lymph node. After general examination, there is abdominal examination in a form of inspection, palpation, auscultation. There is no percussion in a pregnant lady. Palpation divided into superficial palpation and deep palpation. In a deep palpation, there is obstetric maneuvers or obstetric grips called Leopold maneuvers, fundal grip, lateral or umbilical grip, third Leopold and fourth Leopold. By inspection, after adequate exposure, patient should be exposed, as we say, from sternum to pubic hairline. Comment on abdominal contour, flanks, full flanks or not. In a pregnant lady will be full flanks due to displacement of small and large intestine by gravid uterus to the flanks. Symmetry. Regarding surgical scars, comment on a type of surgical incision, its site, and on a hearing. By inspection also comment on fetal movement and abdominal movement with respiration. Umbilicus, is it inverted or flat? Linea nigra and striae gravidarum, which is symptoms of pregnancy. Striae gravidarum mainly in the lower abdomen and towards the flanks. The recent one will be purple in a fair colored patient, and the old will be white and it's called linea albicans. Comment on hernial orifices, which is inguinal, umbilical, femoral, and incisional hernias. This is striae gravidarum and linea nigra. Abdominal examination by palpation, there is superficial and deep palpation. Superficial by palm of the hand, usually anti-clockwise, and look at the patient face for tenderness. We are looking for, by superficial palpation, tenderness, guarding, rigidity, temperature, superficial masses, amount of liquor, and any uterine contractions. By deep palpation, first for organomegaly, liver, spleen, and kidneys, and for obstetric grips, which is Leopold maneuvers. First of all, in abdominal examination for obstetric maneuvers, fundal level or fundal height. The landmark for fundal level is the sternum and symphysis pubis. Fundal level, the approximate duration of pregnancy in weeks, and to be compared with gestational age from history taken. Does it correspond to heart rate, fundal level less than that, or fundal level more than that? It's done by two methods, either by finger method or by the tip. In a finger method, each one finger equal to 2 weeks. And by tape methods, which is called symphysis fundal height by centimeters, each 1 centimeter equal to 1 week. This is tape method to measure symphysis fundal height in centimeters. To measure fundal level, first correct uterine dextral rotation, usually gravid uterus, dextral rotate to the right side by sigmoid colon. So first correct this dextral rotation by dorsum of the right hand and use the ulnar border of the left hand to define the fundus of the uterus. After you identify the uterine fundus, measure the distance between the uterine fundus and the sternum by fingers, and as we say, each finger equals to 2 weeks. To measure symphysis fundal height, we'll measure the distance from the symphysis pubis to the uterine fundus by tape in centimeters, and each 1 centimeter is equal to 1 week. So fundal level by fingers from fundus to the sternum, and symphysis fundal height from symphysis to the fundus by tape in centimeters. تمام. In measuring fundal level, there is a fixed points correspond to certain gestation eggs. Example, fundal level at symphysis pubis equal to 12 weeks, at the umbilicus equal to 24 weeks, and midway between umbilicus and symphysis pubis it's equal to 16 weeks. As demonstrated in this picture, fundal level at symphysis pubis is equal to 12 weeks. At umbilicus it's equal to 24 weeks. Midway in between it's equal to 16 to 18 weeks. From umbilicus to the sternum is divided into 3 equal parts. The first 1/3 is equal to 28 to 30 weeks, as the sternum is equal to 36 weeks. The junction between lower 2/3 and upper 1/3 is equal to 32 weeks. تمام. At 40 weeks, due to fetal engagement, fundal level will be regressed from the sternum to level of 32 weeks, which is junction between upper 1/3 and lower 2/3. In a clinical examination, to differentiate between gestation age, is it 40 or 32 weeks, check for fetal engagement. If the fundal level at 32 weeks and fetus engaged, this is correspond for 40 weeks gestational age. And if the fundal level at 32 weeks and fetus not engaged, so it's correspond for 32 gestational age. تمام. طيب, as we say, the distance between umbilicus and the fistula is divided into 3 equal parts. At the junction of the lower third and upper 2/3, it's 28 weeks. The fundal height at the junction of upper and middle third is correspond for 32 weeks, and at the level of the sternum, it's 36 weeks of gestation. At 40 weeks, the fundal level comes down to 32 weeks due to engagement of the presenting part, which is the differentiating point between 40 and 32 gestation age. In obstetric maneuvers, the first is a fundal grip. تمام. Fundal grip used to know which part of the fetus occupies the fundus. Either head, which will be rounded, hard, regular, and palatable, or the fundus occupied by the fetal buttocks, which will be soft, irregular, broad, and non-palatable. This is how to check for fundal grip. Use both hands over the fundus and estimate which part of the fetus occupies the fundus, either fetal head or breech. In a transverse line will be empty fundus. Second grip, called lateral or umbilical grip. Lateral grip used to identify lie, fetal lie, and fetal position. Fetal lie, by definition, is a relation between longitudinal axis of the baby and longitudinal axis of the mother. Will be either longitudinal lie, oblique lie, or transverse lie. For example, if this is the abdomen, this will be longitudinal lie if the fetus lying in this direction. Either will be cephalic or breech. This longitudinal lie. This is oblique lie, and this will be transverse lie. This is the fetal lie. The fetus lying transversely in relation to longitudinal axis of the mother. The second concept is a fetal position and has two definitions. First, defined as relation of the fetal back to the right or left side of the mother, and whether it's directed anteriorly or posteriorly. Other definition, position is a relation of the fixed point in the presenting part of the fetus to the 4 quadrants of the mother, either anterior, posterior, right or left. تمام. The fixed point depend on fetal presentation. In a cephalic presentation means fetus presented by fetal head. تمام. So the fixed point will be the occiput. And in breech presentation, which means fetus presented by his buttocks, and the fixed point will be the sacrum. This picture demonstrates various fetal position as predicted by abdominal examination. In right occiput anterior, right occiput transverse, and right occiput posterior, the fetal back directed to the right side of the mother. Regarding fetal occiput, as in this picture, either directed to the symphysis pubis, which is occiput anterior, or directed to sacrum, which is occipito-posterior. If the occiput to the right side, it's right occipito-transverse. If the occiput to the left side, it's left occipito-transverse. For doing lateral or umbilical grip, you will be facing the patient. Two hands placed on either side of the umbilicus. One hand will be fixed and the other palpating to determine the fetal back. The back will be smooth, curved, continuous, and has resistant feeling. The limb side will be relatively empty and contain irregular parts. This is a maneuver of doing lateral or umbilical grip. Two hands on either side of the umbilicus. One will be stable, fixed, and the other palpating alternatively. First pelvic grip, also called third Leopold or Pollock's maneuver. To determine presentation. Presentation by definition is the fetal part that related to pelvic brim or first fetal part felt during vaginal examination. Presentation would be either cephalic, breech, or shoulder presentation. Also there is a compound presentation, brow presentation, and cord presentation. The commonest or the normal presentation is a cephalic one. This is the vertex to the right side or cephalic presentation. In breech presentation to the left side, the fetal buttocks or breech will be the first presenting part of the fetus. Second pelvic grip for engagement of the presenting part. Engagement by definition is the passage of the widest diameter of the presenting part through the pelvic inlet, by means that the presenting part, whatever its vertex, breech, shoulder, whatever, the widest diameter of this presenting part when it crosses the pelvic inlet, this is called engagement. For doing first pelvic grip, facing the patient, the inner border of the right hand will place over the outer border of the symphysis pubis. The thumb will be in one side and four fingers in the other side. As demonstrated in this picture, the four fingers in one side and overstretched thumbs in the other side. This is a first pelvic grip facing the patient, determining fetal presentation. Regarding second pelvic grip, in this part we will face the patient feet using two hands, four fingers of the both hands placed parallel to inguinal ligament on either side of the midline. The fingers pressed downward and backward to approximate fingertips to check for engagement of presenting part. This is second pelvic grip, facing the patient feet using two hands, four fingers of the both hands parallel to inguinal ligament on each side of the midline, checking for engagement. This is a summary of obstetric grips. A. Demonstrate fundal grip to determine which part occupy the fundus. B. Demonstrate lateral or umbilical grip for lie and position. C. Demonstrate first pelvic grip for presenting part for presentation. D is the second pelvic grip for engagement of the presenting part. The last step in obstetric examination is auscultation for fetal heart sound, which is best audible through the path, mainly left subscapular region. As a rule, maximum intensity in a cephalic presentation is below the umbilicus, at midpoint between anterior superior spine and umbilicus. The normal rate of fetal heart sound from 110 to 160 beats per minute. Auscultating for fetal heart sound using either binaural stethoscope or Doppler ultrasound. Complete examination by checking for lower limb edema, check for varicose veins, recover the patient, and explain the examination is finished. Allow patient to read rest in privacy, thank the patient for their time, dispose PPE appropriately, and wash your hands. Summarize your findings in a form of positive findings in general examination, fundal living weeks, lie either longitudinal, transverse, or oblique, presentation either cephalic or breech presentation, Other abnormal presentation of shoulder presentation, brow, and compound presentation. Position according to presenting part, the fixed point, encephalic presentation whole occiput, embrace presentation sacrum صح؟ The position either right occiput anterior, right occiput transverse, right occiput posterior, left occiput anterior, left occiput transverse, or left occiput posterior. Direct occiput anterior and direct occiput posterior. This is a possible fetal position. In a summary also, mention is it presenting part engaged or not, fetal heart sound positive or not. If it is positive, mention its rate in a form of beats per minute. This is the end of the lecture. Thank you.